Okay, good afternoon, everyone. So today we'll be learning about papillitis and papilledema. So whenever it comes to neuro-ophthalmology, one should all, of course, understand about papillitis and papilledema. So what is papillitis? For example, if you look into the discs, you have your optic discs and you have your macula. So what do you need to really understand from this optic disc and a macula is whenever there is hyperemic border. For example, if I zoom in this optic disc, okay, like this, okay, there is leakage, particularly there is leakage, okay, from the blood vessels. So you have a lot of blood vessels encroaching towards this optic disc, okay, like this. So these are the blood vessels which are encroaching towards the optic disc, and there is particularly leakage from these blood vessels that will actually lead to formation of a blurred margin around the optic disc, and this is actually a classical hallmark of papillitis, that is formation of a blurred margin around the optic disc. So whenever we talk about papillitis, we have three types of papillitis. One is basically these papillitis comes under optic neuritis, okay, optic neuritis, okay. So optic neuritis, it has three entities. One is papillitis, the other one is retrobulbar neuritis, RBN, retrobulbar neuritis, and the next one being the neuroretinitis, okay, the next one being the sorry, neuroretinitis. So what is neuroretinitis? Neuroretinitis means you have papillitis over here at the optic disc, and in the macular area you can see something which is known as a macular star. And what is this macular star? This macular star is nothing but is actually this leakage which has occurred from the blood vessels around the optic disc has actually involved the macula, and this is known as the macular star, okay. Now we need to understand about retrobulbar neuritis. So what is the component of retrobulbar neuritis? Suppose this is your optic disc and this is your eye, okay. So particularly at the back of your eye you have your optic nerve traveling like this. So what happens in the retrobulbar neuritis is basically there is actually inflammation of all around this area, at the area of the back of the eye. There is all inflammation, okay. This whitish is all inflammation. The thing that you need to remember here is the superior rectus is actually being inserted over here, okay. Some of the fibers of superior rectus actually, it also inserts at the top of the optic nerve like this. That is why there is eye pain when you elevate the eye. There will be eye pain, okay. So it's a classical hallmark of retrobulbar neuritis. So retrobulbar neuritis is most common and it is usually associated with multiple sclerosis. So from where this multiple sclerosis has arisen now? So this optic neuritis can actually be classified on the basis of etiologically. And optic neuritis, if you classify it on the basis of etiology, you need to understand that it is divided into demyelinating disease. And what is this demyelinating disease? Demyelinating disease means, suppose this is your nerve fiber and here you have your nerve and then you have your myelin sheets like this, okay. So if these myelin sheets, they do degenerate, okay, if there is degeneration of this myelin sheet, then there is actually deposition of the plaques around this myelin sheet. And whenever there is deposition of plaques around this myelin sheet, what happens is the conduction is delayed, okay. The conduction is delayed. So when the conduction is delayed, of course, in our eye, the best method to understand the conduction is actually, one is accommodation, the other one being the constriction of the pupil, right? So the major one being the constriction of the pupil. So that constriction of pupil will be, defective. So that is known as RAPD. So relative afferent pupillary defect is actually a hallmark that is seen in all the kind of optic neuritis. But you have an exception. What is that exception? That exception is in the case of optic neuritis. In the case of optic neuritis, you'll have total afferent pupillary defect, okay. That is known as TAPD. That means the pupil will not actually react, okay. And in the case of disc edema, there is RAPD is not seen. That is, the pupillary reaction is normal, okay. But in the case of demyelinating disease, you will see, of course, RAPD, okay, reactive afferent pupillary defect. And of course, there is more like infectious. One is demyelinating, number two is infectious, number three is autoimmune, number four is your viral, okay, number five idiopathic, number six metabolic. So metabolic like diabetes mellitus, hypertension, viral like measles, mumps, rubella, chickenpox, etc. Autoimmune like Conditions like Guillain-Barré syndrome. There might be systemic lupus erythematosus, Guillain-Barré syndrome. These are the different association of optic neuritis. And infections, as I already told you, infection, it might be bacterial, it might be viral, it might be protozoal. Okay, so Lyme disease, syphilis, okay, so TB, leprosy, all these conditions can actually eventually lead to optic neuritis. Now what more means infection, maybe because of streptococcus, maybe because of staphylococcus, can land into formation of what? Orbital cellulitis. And from orbital cellulitis, it might actually land up into optic neuropathy. So this optic neuropathy is eventually, what we understand from optic neuropathy is any pathology from the retina. There's nerve fibers, and any pathology from the retina, it goes towards the brain. And this pathway, if it is halted, if there is disrupted, if it is interrupted, then that will lead to optic neuropathy. So are we getting this point till here? Okay. Now we need to understand about the demyelinating disease. So I already told you about multiple sclerosis, but apart from multiple sclerosis, there is something which is known as Childers disease, Schilders. Okay, this S is silent. Okay, that's why it's known as Childers, Childers. And other one is Devick's disease. And Devick's disease is also known as neuromyelitis optica. Neuro means nerve fiber, myelitis means demyelinating disease, optica means towards the eye. So neuromyelitis optica, also known as Devick's disease. So this was about optic neuritis. And one more thing you need to remember, that the association of optic neuritis with, that is Uthoff's phenomena and Pulfric's phenomena. So Uthoff's phenomena means whenever you just go for an exercise, then after coming from the exercise, you'll have severe eye pain. Okay, and that is a classical feature that you see in the case of optic neuritis. And Pulfric's phenomena is basically a condition where there will be difficulty in stereopsis. So what do you mean by stereopsis? Stereopsis means 3D vision. Okay, stereopsis means 3D vision. The background noise of the crow is really distracting, but just be focused, okay, in this one. So difficulty in the 3D vision. Now the next thing that we need to understand is there are various methods by which we understand this 3D vision. So okay, wait a second. Okay, so whenever we talk about this phenomena of whenever we talk about the phenomena of understanding this Uthoff's and Pulfric's method, the phenomena is actually, it's not well known, okay, why there is Pulfric's, why there is Uthoff's. But the thing is, eventually it will lead to eye pain, and these are responsible for causing papillitis. That's it. Now, how the patient will present in decrease in the visual acuity, decrease in visual field, decrease in pupillary reflex, decrease in contrast sensitivity, decrease in color sensitivity, all the feature, because it's the nerve which is responsible. Eye is a camera, nerve is your transmitter, your brain is the receiver, the brain interprets, right? So any problem with this nerve, all these defects are seen. There will be exceptions, and I'll tell you about the exceptions. Rather, at all areas you will be seeing this phenomena. Okay, now remember that someone who is having multiple sclerosis can also present with nystagmus sometimes. Okay, so if the patient has multiple sclerosis and you diagnose it that, okay, this is a case of optic neuritis, or you just diagnose it case of optic neuritis, simply an optic neuritis, there might be multiple sclerosis, there might not be, there might be other conditions. What will be your treatment for optic neuritis? Treat the cause. Number one, in any of the cases, papilledema, treat the cause. Dick's edema, treat the cause. Papillitis, treat the cause. If it's an infection, give antibiotics against infections. Okay, treat the infections. If the infection has come from sinusitis, refer to ENT. They will manage it, and this one will be okay. But what about actual condition of this one? So for example, if someone's having multiple sclerosis and the presentation is optic neuritis, you will give IV bolus steroid, okay? And here you'll give methylprednisolone. You'll give this for 3 days. You'll give it 1 gram. And after 3 days, you'll shift to oral. In oral, you'll prescribe as 1 mg per kg body weight per day, okay? And this just give it for 11 days. Then you taper. Okay? If it's a case of steroid resistance, what did I say? IV bolus for 3 days. Then for 11 days, you'll give oral steroids on the basis of 1 milligram per kg body weight, okay? Newer modality, you can give monoclonal antibiotics. You can give interferon beta, okay, like this. Now let's talk about papilledema. So what is papilledema? Now I already told you about the disc changes, okay? I don't think much more needed. One is papillitis, other one is retrobulbar neuritis. Retrobulbar neuritis, nothing is seen, okay? This is also normal. The doctor will also not say anything. The patient will also not see anything in the case of retrobulbar neuritis. This presentation is pain on elevation of the eye. And the second one is neuroretinitis, which is least common. This is there will be papillitis as well as macular star, okay? Apart from this, if you look into the discs carefully in the case of papillitis, in the case of neuropapillitis, what will you see is, you will see the blood disc margin like this. Blood disc margin, okay, very good. And next thing, please make pictures along with me, okay, with different color pencils. Next, you'll see retinal veins being very, very tortuous. Retinal veins are very, very tortuous. Since it's a case of leakage, so what will you expect? You'll expect some hemorrhages. Right? So these splinter hemorrhages you'll expect, okay? And of course, there is a component of your hard exudate and soft exudate. Soft exudate is your, what do you mean by soft exudate? Soft exudate means cotton wool spots. Hard exudates means your this, what is this? This is your exudates, fine exudates, okay? This is your hard exudates due to leaked this is due to leaked lipids, okay? Leaked blood vessels, and there is less one. And then leakage, you can show it like this. So you can just make like this kind of diagrams in your exam also. You know, it's very good to see like this kind of diagrams. Now next is papilledema. So what is papilledema? Papilledema is a condition of disc edema which happens secondary to increase in the intraocular pressure. So any problem in your brain, any problem with the aqueous humor secretion and aqueous humor drainage, it will lead to papilledema, okay? It will lead to papilledema. So I will give you the different causes, list of causes of this one. So first one you need to understand about is idiopathic intracranial hypertension. Okay, I'll just, my NRT is not that good, just understand, okay? Idiopathic intracranial hypertension. In this one, you need to understand about sleep apnea, obesity, vitamin A toxicity, OCP, tetracycline, or intraocular space occupying lesion. So what can that be? That can be a tumor, that can be a brain abscess, that can be a what can there be? Just understand, meningioma. Okay, that is just compressing the brain, increasing the intraocular. There may be infections. Maybe there might be meningitis. Meningitis may be viral meningitis, maybe bacterial meningitis. Okay, viral and bacterial meningitis, or it can just be a, the flow of CSF is disrupted. How? Because of certain strictures. There may be certain strictures. There may be certain tumor compressing the drainage pathway. Okay, or there might be anyways there will be excessive secretion of the CSF or decrease in the drainage of CSF. All will actually lead to increase in ICP. Of course, there will be lateral sinus thrombophlebitis, okay, from your ENT, from your dural venous sinuses. In the dural venous sinus, there might be thrombus, okay, so cerebral veins, there might be thrombosis, there will be hypertension. All this way, whenever there is an increase in the ICP, there will actually lead to papilledema. The most important thing that we need to remember is, whenever there is all this component of disc edema, the thing is the pathophysiology. So there will be swelling of axons, okay, swelling of axons. There will be swelling of axons, and that will lead to, there's a swelling of axons, there's edema, there will be pressurized effect to what? To veins, and that will lead to leakage. So when there is leakage, already we understand that the discs will be blurred. Okay, but here the discs will be so much blurred. It's given like more than 3 diopters blurriness. Okay, in the disc, it might reach to 6-7 diopter blurriness of the discs. The disc is sometimes, it's so much blurred that we can't even interpret, like, is that really a disc? Okay, so much blurring of discs. It might be like this, blurring of disc, very big discs it has become. And copying is actually also altered, physiological copying is also altered, right? And of course it will lead to different condition. What will it lead to? So actually it's divided into different stages. Okay, stage 1 papilledema, stage 2, stage 3, and stage 4. So stage 1 is initial papilledema. Okay, so it's just a early stage of papilledema. Then you have early stage. Okay, one is the early stage, second one is advanced papilledema, fourth one is atrophic. Okay, established papilledema, fourth one is atrophic papilledema, and third one is chronic papilledema. Okay, first one is early stage, second one is acute papilledema, third one is chronic papilledema, and fourth one is atrophic stage. Please learn along with me once again. Early stage, then you have established papilledema. Okay, then you have chronic papilledema, then you have atrophic stage. So what will happen is, initially the disc blurring, it occurs from the nasal sides. I made this temporal, okay, not this one. Initially the disc blurring occurs from the nasal side like this. Okay, and of course there won't be any kind of visual acuity changes, there won't be brightness changes, there won't be color sensitivity changes. Everything is normal. Okay, everything is normal. Now slowly what will happen is, in the case of established papilledema, all the surrounding discs will be edematous, and it will look like this pattern. See here, there'll be leakage, there'll be exudates, there'll be hemorrhages. This is a hemorrhage, this is exudates, there will be exudates, and the veins will be dilated, okay. And of course, as the disc has enlarged in size, you know that in your visual field charting, the disc is represented by the area of the blind spot, so that area will also increase in size, isn't it? So there's an classical increase in the blind spot area, constriction of the visual field. And this constitution of the visual field may be a centrocecal, it may be a paracentral, it might be a altitudinal. This altitudinal is usually seen in the case of arthritic type, but in the case of papillitis and papilledema, it might be centrocecal or central. Okay, centrocecal center. And the next classical feature that we see in the case of established papilledema is Parton's line. Okay, so what is Parton's line? Chorioretinal fold. So you make like this. Red is your choroid, yellow is your retina. So chorioretinal folds. This is known as Parton's line. That is classically seen in the case of this one. So visual field will start to decrease from papilledema, but it won't have completely decreased. Okay, so visual field, it is starting to decrease. That's it, you need to write. Now let's come to chronic and atrophic. Okay, this is important and often students get confused over here. Now in chronic papilledema, what is going to happen? In chronic papilledema, suppose this is your disc, right? So all around you'll have drusen like material. So let me just take a brown color. Okay, so all around you'll have your drusen like material. It's not well seen in this particular background, but you'll have drusen like material all in the background like this. And this drusen like material which is seen in the background is actually nothing but this is actually known as corpora amylaceae. So this is known as corpora amylaceae. Along with that, there will be constriction of the visual field, Dick's edema, all these things that you need to write. In the case of atrophic papilledema, the classical thing that you will see is, what will you see in the classical thing in the case of atrophic papilledema, that you will see that the disc has actually deviated. It looks like this, okay, because there's so much of blurring, and this is your blood vessels. The attenuation of the blood vessels is seen, and all around the blood vessels, what you will see is, you will see a whitish sheath around the vessels. So whitish sheath around the vessels like this. Whitish sheath around the vessels. Okay, the blood vessels are attenuated, narrow blood vessels, and this optic disc, so much of blurring of the optic disc, that the disc, the prominence of the disc is not seen. It might be deviated type of disc. I told you the disc edema is so much. Okay, and remember that long-term deficiency of vitamin D can also lead to papilledema. So this is one of the kind of MCQ. And one more thing I would like to add upon here. Patterns line you understood. You understood about the constriction of the visual field. You understood of the corpora amylaceous seen in stage 3, right? One more thing I would like to add upon here is the champagne cork appearance of the optic disc. So if you see the optic disc over here, so let's rub the optic disc again, and let's make it again. So the optic disc, it looks like a champagne cork, so like this. Actually champagne cork it's like this, the one with which you open your wine bottle, right? Now the optic disc will look like this. This is excessive blurring. Okay, so this is